Good day, everyone. I'm Visahi Sivomar. I have just completed my MBBS degree from University of Sri Javatanapura. I'm planning to do ERPM classes online. I'll be giving recorded videos. So this is my GNUP session. So as a free introductory session, I plan to do physiological changes in pregnancy. Because in MCQs, you will be definitely get one MCQ, true or false, regarding physiological changes in pregnancy. So it's a very important topic. Let's start. Normal pregnancy. In pregnancy, the duration is important because there's an estimated date of delivery and the last regular menstrual period, first day of last regular menstrual period. All those things, you should know about those things. And usually in human pregnancy period is 280 days, which is usually dating. That means the age of the fetus is calculated using ultrasound scan, which is done from 10 to 13 week, 13 plus 6 days actually in Sri Lanka. In Genonop's field, the difference between other subjects and Genops is Genops, they regularly changes the guidelines in every year likewise. So there will be more updates, and in exams, they will be expecting whether you are updated or not. And there are changes from countries to countries regarding the laws in genomes. So it's important to know what is followed in Sri Lanka, Sri Lankan board setup. You should know most of the things. Also, they appear in community medicine MCQs as well, because most of the more age-related things are related to pregnant women as well as children. So you should be thorough with it. And in cases as well, the POGs, the examiners will be asking questions in and out. They are most interested in social history and your community medicine level knowledge in gynecology, genomes. So and also these physiological changes is important, as it will appear as a definitely it will appear as one of the MCQ. So in Sri Lanka, dating scan, ultrasound scan, I will be discussing about the scans in detail in the future session. 10 to 13 plus 6 days and estimated date of delivery is calculated using crown drum length or head circumference in ultrasound scan. These all points are MCQ points. So you should be 100% thorough with this note, as any of the sentence in this note can appear as a MCQ stem. And estimated date of delivery, ultrasound scan, usually in the MOD setup, the midwife will calculate the estimated date of delivery according to the first day of last menstrual period. And then the mother will meet VOG, and ultrasound scan is done, and the ultrasound scan date will be given. If there is a difference, there usually there won't be much difference. If the menstruation is irregular, and the mother doesn't remember the actual date of last regular menstrual period, the ultrasound scan can be used to calculate the time. So if there's difference of more than 4 days between ultrasound scan and estimated date of delivery, the ultrasound scan date, I mean the age of the fetus, is taken according to ultrasound scan. If it is more than 4 days difference between estimated calculated date of delivery, is calculated as 9 months and 7 days from first day of last regular menstrual period. If it's more than 4 days, we take the ultrasound scan. And the head circumference is usually done in second trimester. And if it is more than 7 days, then ultrasound scan head circumference is taken as a estimated date of delivery, because the mother might she might not know that she is pregnant, and she will be presenting to the VOG during second trimester. In that period, usually the head circumference is taken to calculate to take the estimated date of delivery, the scan date of delivery. Okay. Okay, there are some terms in GenOps. Viability. What's viability? Viability means it's a potential of the fetus to survive outside the uterus after birth, natural or induced. The birth can be natural birth or induced birth. So, but the fetus should have the potential to live, to survive outside when supported by up-to-date medicine. And the International Classification of Diseases defines term pregnancy as delivery between 37 weeks, 0 days, and 41 weeks plus 6. This is important because in Sri Lanka, 37 weeks is defined as term pregnancy. Before 37 weeks, if it is delayed by even 2 or 3 days, it is not a term pregnancy, it's preterm. From 37 weeks until 41 plus 6, it is preterm. After 41 plus 6 days, it's more than 42 weeks, we tell it as postterm. So preterm is less than 37 weeks and postterm is greater than 42 weeks. And there are three trimester, first, second, and third. And you should know some of the terms accurately in GenOps. Gravidity. What is gravidity? Gravidity means it's denoted by letter G. In Sri Lanka, usually pregnancy record is given to all the women and who are pregnant. And then the pregnancy record, there are 3 letters, G, P, C. You should be thorough and you should know what this GPC means, and you should be able to fill as a house office as well. Gravidity means total number of pregnancy regardless of duration or outcome. If a woman gets pregnant, whether it ended up in a miscarriage or neonatal death or a preterm delivery, term birth, healthy baby, regardless of that, regardless of duration, the gravidity is given. If a woman gets pregnant for 3 times, G is 3. Then parity. Parity means number of pregnancies completed to delivery during viable period. Okay. Viability. Here is a difference because in Sri Lanka, 24 weeks is considered as viable according to Sri Lankan resources. The child born after 24 weeks can be he can be secure because child can live if born after 24 weeks. So, according to Sri Lankan setup, the number of pregnancies completed to delivery during viable period beyond 24 weeks, even if it is a miscarriage. If it is a miscarriage on your that's we don't need that. If the mother has passed more than 24 weeks, we take count of parity. That means if I have already said a woman gets pregnant 3 times, and one ended up 12 weeks as miscarriage, and second one ended up as 25 weeks neonatal death, and the third one ended up as 26-week preterm baby. Okay, now for this woman, G is 3, and there are, for P, we won't take this first one. We won't take into account because it is less than 24 weeks. But other two are, with, though it is neonatal death, and one is a live baby, still we take these two into account because these are more than 24 weeks. So we take as P2. Okay. And C4, alive children. It means the children who are alive currently. It's a crude thing, actually. The children who are alive currently. For this woman, only one baby is born alive. Okay, only one baby is born alive. But this baby died by 1 year due to road traffic accident. Let's take it as a road traffic accident. So currently, she doesn't have any children alive currently. So C is 0 because she doesn't have a live baby currently. So you should be thorough with GPC because as a house officer, you have to fill these in your records and you will be asked in the exams as well. Okay. And if the woman is pregnant, she can diagnose it using urine HCG. It's a main test. Usually, in 14 days after conception, the mother becomes positive. This you all know. Okay. Then for diagnosis, whether a woman is pregnant or not, there are many things. In the histories as well, you have to elicit all, you have to ask all these symptoms and signs, and you have to present. And observation, they will be expecting for all those. And so the symptoms are usually nausea, vomiting, tiredness, fatigue, cravings for food or something. The woman will miss a period like this. But all the symptoms won't be there in all the women. And some of the symptoms will be severe, mild, moderate, or severe. So it will varies from woman to woman. In the histories, you have to differentiate that. And signs, as a sign, there's a sustained body basal temperature. We will be discussing about these things regarding menstrual period in gynecology. And there's a Chadwick sign, Goodell sign, Osiander sign, Kaga sign. There are a lot of things, but you don't need to know all these things as an undergraduate level. They won't assess these things in ERPM exams. Hyperemia, there can be hyperemia and softening due to progesterone or HCG. These things can be, you can tell, like the cervix will be hyperemic, soft. It's due to progesterone hormone. And you can use investigations. I always tell, for any diagnosis, any disease or pregnancy or anything, always start with history, examination, and investigation. Don't jump first into the investigation. So diagnose pregnancy, symptoms, signs, and then as an investigation, urine and serum HCG or ultrasound scan can be used. Okay, what's Chadwick's signs for interest, but it's not a must. There's here in the picture you can see bluish pink appearance around the vulva and vagina, and it looks little dilated. But you don't need to know about this. They won't assess this in the exam. These are gas signs. It's not a must, but for interest you can search. Okay. Confirmation of the pregnancy and the location where the pregnancy is situated, it's a must. Whether it's an intrauterine pregnancy or ectopic pregnancy, or whether pregnancy of unknown location, the VOG usually tell all those things. And about the viability and the complications of early pregnancy, all these will be discussed in the future sessions. Okay, these are a table, but you don't need to by heart all this. And in the first trimester, dating scan is done, and estimated date of delivery, location, possible complications, all are discussed with the mother. Okay. And the very important thing in the when you are presenting the histories in genomes, don't tell as a patient. Address as mother or by name. Name is okay. Don't leave this patient presented because pregnancy is not a disease. Okay, it's a physiological change. Okay. Now let's discuss about the important topic that the physiological changes in pregnancy. You should be very thorough with all the systems changes by trimester wise during pregnancy. Definitely you will get one true false complete question in this. Okay, cardiovascular system. In the cardiovascular system, the circulating blood volume will be increasing by 40 to 45% during pregnancy. And the cardiac output, 43% in cardiac output. The cardiac output will be peak around 28 to 32 weeks of gestation. Because due to progesterone, there will be water retention and the cardiac output will be increased. And due to this only, the symptoms are exaggerated. Examples for if the patient is a non-patient with heart disease or anemia, those symptoms will be exaggerated during 20 to 32 weeks because the cardiac output will be increased at to a peak value during 28 to 32 weeks. And the resting heart rate will be increasing by some 17%. These all are important in MCQS. But the vascular resistance, systemic vascular resistance, will be decreasing by 20% because the peripheral resistance will be reduced due to the effect of nitric oxide. Okay, this is a MCQ. This is the peripheral resistance will be reduced is an MCQ point. And due to that, blood pressure depends on vascular resistance. So blood pressure also drops. So in pregnancy, circulating blood volume increases, cardiac output, resting heart rate increases, but the vascular resistance and the blood pressure reduces. And in the diaphragm, displaces heart and to the left. So there will be larger cardiac silhouette on chest X-ray, left axis deviation in ECG, also small benign pericardial effusion can be there. And heart can be mild dilated, which is physiological. These all are MCQ points. A bit due to the gravity uterus, the heart can be displaced to a bit, and it can be mildly dilated, which are all physiological. But if the mother has a previously heart disease, it can worsen it as well. So these are the important things, whether it's a physiological thing or a pathological thing. When you examine the patient, the cardiovascular system, there will be bounding pulse, collapsing pulse, ejection systolic murmur, third heart sound, ectopic beats, peripheral edema. You don't need to know why these are happening because all these are happening because of the progesterone and the fluid retention. And but these will be checked as MCQ points. And if you do ECG, you don't need to do ECG in all the pregnant women. But if you do ECG, there can be ST segment depression, T wave inversion in the inferior and lateral leads, small Q wave, inverted T waves in lead 3, anterior and ventricular ectopics, left axis shift of QRX complex. And if you do chest X-ray, there will be cardiac silhouette, diaphragm displaces heart and to the left. This is a cardiac silhouette sign. And here an MCQ will come whether these things are physiological or pathological. So I'm now discussing only the physiological thing. So you have to know whether this is normal or abnormal, because as a house officer, if it is normal, you don't need to bother your seniors. But if it is abnormal, you have to quickly address it to the senior officer. So that's why to work as a safe doctor, you should know all these things. Okay. And again, to the respiratory system, the respiratory system, the respiratory rate is unchanged. This is a famous MCQ point. The respiratory rate is unchanged, but the tidal volume increases. Therefore, the minute ventilation increases. The partial pressure of carbon dioxide reduces, and the functional residual capacity also reduces because the gravid uterus will be compressing the lungs, and lungs functional residual capacity reduces. These are also MCQ points. And some women, some mothers will complain dyspnea because there's an increase in demand, maternal need, and also the uterus, the growing uterus will be pushing on the diaphragm, and some experience dyspnea, which is a common complaint. These all are physiological changes. At which extent it will change to pathological, you should know. And it's a hormone-induced, usually the tidal volume increases by 40%. It's usually a hormone-induced thing. And partial pressure of carbon dioxide reduces, and the normal pregnancy value is 30. Functional residual capacity also reduces, as I said before. So these are the MCQ points. So remember all these points. Increased tidal volume, respiratory capacity will increase, residual volume rate reduces, expiratory reserve volume reduces, functional residual capacity reduces, total lung capacity, it won't change because you are not cutting and removing a lung. Lung is still there. So total lung capacity won't change. It will be equal, and capacity, vital capacity will be equal, inspiratory reserve volume will be equal. Equal means it will be as pre-pregnancy level. Okay. But these changes will not alter the lung function test. If you do a lung function test in a pregnant lady, there won't be changes with the pre-pregnancy level as well as pregnancy level. Okay. In the gastrointestinal tract, because of the sphincter relaxation by progesterone is the main organ that's secreted during pregnancy. Because of the progesterone effect, the sphincter relaxation, the mother might experience gastric reflux to due to delayed gastric emptying. These are MCQ points. The gastric emptying will be delayed, and the intestinal motility will be reduced. The lower esophageal sphincter tone will be reduced. These also are MCQ points. So the mother is more prone to get gastroesophageal reflux disease, GERD. All these are physiological. Gallbladder emptying is delayed, and it will be less sufficient than pre-pregnancy. So there's a more risk of cholesterol stone formation. This is a pathological thing, but it can happen. So there's a gestational cholestasis, all those things there, which will be discussed in the future. A mother might experience constipation, hemorrhoids, and you should ask all these things in your history. And the gastric motility will be reduced. These are common MCQ points. And in the genitourinary system, the renal blood flow will increase because the total blood volume will increase, which will increase the renal blood flow as well. And the kidney size also increases, is also MCQ point. And GFR, glomerular filtrate rate, also increases it up to 55% by second trimester, and results in reduction in blood urea nitrogen and creatinine, because they will be diluted. There is more water, more blood, all blood urea nitrogen, creatinine will be diluted and results in reduced concentration. Mother might experience proteinuria, which is physiological up to a certain point, and she can have glycosuria, but not always. So like that, if MCQ point is given, proteinuria is pathological during pregnancy. It's true or false? It can be pathological, it can be physiological. There is a limit. So if it is always pathological, proteinuria is always pathological in pregnancy, it's a false statement, because there can be normal as well. Okay. Then the hematology system. as you all know, 40 to 45% of circulating blood volume is increased, and which increase the erythrocytes as well. The hemoglobin concentration will reduce because of the dilution of intravascular volume, because there are more water, so more blood, so all those will be diluted, and but the hemoglobin is still the same. So hemoglobin concentration, the concentration, because number of hemoglobin over volume is usually a concentration. And here the volume increases, but still hemoglobin number is same. So the concentration of the hemoglobin reduces, and but it should not be below 11 gram per deciliter, because when we are assessing, you can't misdiagnose a normal hemoglobin in a pregnant woman as a anemia, because the usual cutoff for pregnancy hemoglobin level is less for during pregnancy, because for pregnancy 11 gram per deciliter uh, is enough. If it is below that only, we suspect whether the mother has anemia. Okay, but MCHC, mean corpuscular hemoglobin concentration, is unchanged. These all are MCQ points. So emphasize and study on that. During pregnancy, the iron requirements will be high, because the fetus will need iron, and the mother needs iron, so there will be higher iron requirements. And the reticulocyte count, second half during the second half of pregnancy, it will increase. And also leukocyte count range from 5,000 to 12,000 cells per microliter. And here during pregnancy, predominantly there will be neutrophils. These are all MCQ points. They appeared in the past papers. Leukocyte function reduces in the second trimester, so mothers are susceptible to infection. Okay, though the neutrophils count increases during pregnancy, the function of the neutrophils reduces towards second trimester, and mothers are susceptible to infection. So look the difference. The count increases, but the function reduces. The clotting factors, coagulating factors increases. This famous MCQ point. So pregnancy is a sort of thrombotic state, because there are more production of coagulation factors. ESR increases, slight reduction in the platelet levels. These are MCQ points. Okay. And packed cell volume increases, reduces, mean corpuscular volume reduces. The size of one red cell is reduced. Okay. And these also MCQ points. Circulating volume increase, hemoglobin concentration reduced, but mean corpuscular hemoglobin concentration unchanged, and the MCV, mean corpuscular volume of the one volume of the one RBC is reduced. WBC neutrophils increases, but their function reduces. Platelet reduces, but clotting factors increases, like fibrinogen. Anti-clotting factors reduces, like protein C and S. So it's a thrombotic state, and ESR also increases. Okay. Then regarding endocrine system, in pregnancy, hyperinsulinemia and fasting hypoglycemia due to changes in carbohydrate metabolism during pregnancy, insulin level goes up. So due to higher insulin, there will be fasting hypoglycemia. Okay. And there can be postprandial hyperglycemia to altered response to glucose ingestion. The glucose response, glucose metabolism, carbohydrate metabolism, all will be deranged during pregnancy. But still, to maintain the glucose level, there will be high insulin secretion, fasting hypoglycemia, and postprandial hyperglycemia. In thyroid, the vascularity of the thyroid gland will increase, and there will be mild hyperplasia, but clinically detectable goiter is not normal. Usually, physiologically, the vascularity of the gland increases, and there will be mild hyperplasia. This is physiological. Physiological means normal. But if there's a clinically detectable goiter, this is not normal. clinically detectable goiter is not normal, it's pathological. And the free thyroxine and TSH to assess thyroid function is used during pregnancy. So when we are discussing thyroid diseases, will be discussed it in detail. And there are changes in the organs as well. So in the organs, uterus, the weight of the uterus will increase from during pre-pregnancy, it will be 70 gram, and during pregnancy, it will be 1100 gram. And the intrauterine volume will increase from 10 to 5000 milliliter. And the 12-week uterus expands into abdominal cavity. And for the breast, there will breast tenderness and tingling sensation starts during first trimester. Breast also enlarges, nipple size enlarges. There will be more pigmentation around nipple area. And in musculoskeletal system, the hormone relaxin is released from the beginning of the pregnancy, which helps to enable the pelvis to expand during the birth by increasing the looseness in the ligaments around the pelvis. The effects of relaxin also include increased mobility in joints such as hip and feet and start to show at 6 weeks and peak at 12 weeks. There will be collagen remodeling during pregnancy, which is an MCQ point. That's all you need to know about physiological changes in pregnancy, because this is asked. Definitely, you will get one MCQ in your common GenOps paper. And that's all for this introductory session. And I'll be discussing all the cases, history taking, and I'll be doing categorized MCQs in every GenOps subjects during my future classes. And if you want to contact for further details about my classes, you can contact me via my WhatsApp. This is my WhatsApp number. Okay, thank you. Have a nice day.